Welcome. My name is Brad Siff. I'm the founder and president of BioWave. I'm very happy to welcome you to our 19th webinar. I'm very happy to introduce you to our guest lecturer this month. His name is Dr. Raymond Tatevossian. He is the founding partner of Comprehensive Spine and Pain Physicians. They're based in the Los Angeles area. The title of our webinar this month is the use of high-frequency percutaneous neurostimulation, PENS, for the treatment of chronic pain in a private practice setting. I just want to remind you before we start that at the end of the presentation, we will have a live Q&A session, and there is a Q&A button at the bottom of your screen, and you can submit your questions through that Q&A button. So without further ado, I would like to welcome you to Dr. Raymond Tatevossian.
Thank you, Brad. Thank you for the introduction. As Brad said, my name is Raymond Tatevossian, and I'm happy to be joining you guys today for this presentation on BioWavePENS and the experience of using this technology in our practice. And as Brad said, the title is the use of high-frequency percutaneous neurostimulation for the treatment of chronic pain in a private practice setting. So a little bit about my background. I'm board certified in anesthesiology and board certified in pain medicine from the USC Keck School of Medicine here in Los Angeles. I helped co-found our current practice of comprehensive spine and pain physicians, also called CSPP, here in Burbank, California. I also direct and manage the CME program in our local hospital called Providence St. Joseph Medical Center right here across the street from Disney Studios. And I've been in practice for now 17 years. The only disclosure I have is that I'm a consultant for BioWavePENS. So a little bit about my practice. As I mentioned, we're located in Burbank. We have multiple locations. We're mostly an outpatient pain management practice, but we also provide inpatient coverage. This is a part of my team here. We're made up of 3 physicians and now 3 physician assistants or nurse practitioners. So I would describe us as a medium-sized pain management practice. We encompass and cover an area from the San Fernando Valley to the San Gabriel Valley. As I mentioned, we have 3 office locations, but we have multiple satellite locations, so we go to a wide area. We're fairly busy. We see about 20,000 patient encounters per year, and we deal with all types of pain management, orthopedic injuries, injuries from trauma, such as motor vehicle accidents, slip and falls. We also take care of cancer pain. We're located next to a cancer center called the Disney Cancer Center. And of course, we treat very common chronic pain from joint injuries and chronic joint degenerative pain, as well as spine pain. Our payer base is made up of Medicare, PPO, HMO patients. We also have a growing personal injury patients that we see, as well as workers' comp, and I would say a few cash patients also. We're essentially a pain management practice that focuses on interventional pain management, although we do prescribe medications and do comprehensive pain management. And this kind of leads to the segue of how we incorporated BioWavePENS into our practice. This occurred sometime around 2017. And one of the issues that we were having is we have a lot of patients who failed conservative management, basic conservative management, and we had recommended at this point more next step of pain management, which typically was interventional pain management, such as epidurals, other types of injections, radiofrequency ablations. But we noticed that there was a growing group of patients who weren't ready to make that jump. who had apprehension or concern about going on to an interventional procedure, but had failed exhaustive therapy. So we felt that there was a gap of where we had a hard time filling that gap with a certain treatment course, and that's where we came upon BioWavePENS, and we felt that really fit was able to address that issue of further pain management without having to step to a more invasive procedure. So a little about PENS. PENS is also known as percutaneous electrical nerve stimulation. BioWavePENS is the only FDA cleared PENS device. Now there are different types of stimulation devices out there. Many you're already familiar with. One of the common ones is a TENS unit, which physical therapists and chiropractors use commonly and frequently. There are other types of systems like IFC and MES. These are typically found in orthopedic offices. But BioWavePENS is different. It's a more advanced system, and as we'll discover in these upcoming slides, it really is a different type of technology and has advantages of being that. So one nice thing about this device, the BioWavePENS device, is that it doesn't require advanced programming. In fact, there's no programming at all. The system is built in to be user-friendly and easy and efficient, and doesn't take up much time as far as staff and scheduling goes. The system itself, the electrodes are comfortable to use, they're safe to use, and we'll jump further into the actual usage of them. The nice thing is that they do treat more than one kind of pain. We use this to treat both nociceptive pain and neuropathic pain, and we'll go over some of those diagnoses. And the best part, of course, of this new technology, or this more advanced technology, is that the results are also better. We've come to find that out. We're going to review some of the studies that show this, and also our experience. So results are 3 times better than traditional electrical stimulation systems. They tend to have a longer carryover, and that in their immediate use, the patients can have pain relief immediately on the short run for up to 72 hours. With repeated use, we see even greater results. So what are the indications of use for BioWavePENS? Well, in our practice, we tend to use it, as I mentioned, for patients who failed basic conservative therapy. We usually time that out in the first 6 to 8 weeks. And most patients have already failed these therapies by the time they see us in our practice. So this is failure of anti-inflammatories, acetaminophen. They've already had 6 to 8 weeks of chiropractic therapy or physical therapy. These patients tend to have pain scores that average between 4 and 8 on a visual analog scale. They tend to have spine-related pain, facet pain, degenerative disc disease, disc bulge, and disc herniations. And they also tend to have joint-related pain, degenerative joint disease, or ligament and tendon injuries. So in these patients who have failed these conservative management, the next step options are typically injections or surgery. As I mentioned, we have a large group of patients who still wish to continue further conservative management. They have apprehension. They may be scared of injections. They may be worried about complications. They may have heard stories, or searched online and are concerned about procedures. And also the other issue might be that they just haven't built rapport with our practice. So and now you take that on top of the fact that there are additional costs and cost concerns and financial concerns with more invasive procedures. So this is a great area where we can incorporate something that's less invasive, but provides something a little bit more than failed conservative management. And this is where we feel in our practice BioWavePENS fit that mold. Now, on the other hand, the other nice thing about this technology is that really the contraindications are minimal, and we'll see the complications are minor, if none at all. What are those contraindications? Of course, infection at the site of application of these electrodes is a contraindication. Patients who have pacemakers or AICDs, you want to avoid those cases. And pregnancy, we tend not to use it for pregnancy. I think there is probably some room to use it for pregnancy, and we can dive more into that in the question and answer sessions. So what is the protocol that we use? So we recommend somewhere between 4 to 6 treatments per pain area over the course of 2 to 3 weeks. Most patients will average about 2 treatments per week. but again, we have a lot of patients who have very busy work schedules, so we're flexible on that. Um, the goal is to complete all the treatments and then schedule a follow-up appointment. So typically a follow-up is scheduled between 2 to 3 weeks after the last session for that, for all the sessions. So if we do 4 cervical sessions, we may do 4 or 6 lumbar sessions, and then we will schedule a follow-up 2 weeks after the culmination of those sessions. The other nice thing is this is applied and managed by the medical assistants in the office. Of course, the physicians and the nurse practitioners are available and close by if there's any need. But typically, this is easily managed by the medical assistants, their application and monitoring of these patients, which we will describe further. So what is our experience? Our experience has been encompasses about 4 to 5 years of using this device. We've estimated about 3,000 pen sessions performed to date. On average, I would say we see about 40 to 60% pain score decrease on the visual log analog scale. And the other nice thing that we've come to find is that a majority of our patients that have these BioWavePENS treatments end up satisfied with their care, satisfied with their pain management, and don't go on to further interventions. In other words, only 20% of our patients, roughly 20% who have had of the entire group of BioWavePENS treatments, only 20% go on to further interventions. Well, you might say, well, how is that helpful for your practice? That means less revenue or less procedures. Actually, we found out that's not the case. The reason is we were able to build rapport with these patients. We also felt that some of these patients that were not going to have interventions anyway, so we were able to take advantage of offering them some treatment, and they would not be lost to follow up or lost from the practice. And also, of course, when you have a satisfied patient, they go and tell their friends, they go and tell their physical therapists, their physicians, and it really becomes a snowball effect of further referrals down the line. So what is BioWavePENS technology? What is it trying to address? Well, as we discussed previously about TENS units, one of the issues that we have with traditional stimulation systems is that they create a low frequency signal, and this signal it's a transcutaneous signal, so it's trying to penetrate the skin. Of course, the skin has very high impedance and capacitance, and so it's not able to really deliver the electrical signals deeper into the tissue where the nerve fibers are and where the pain signals are being processed. So the low frequency signals only travel along the surface of the skin. Again, fundamental issue with TENS units. Now, of course, there is technology to address this. And you may have, if you're in pain management, you have obviously you may have heard and also practice spinal cord stimulation or peripheral nerve stimulation, and that can address this shortcoming. However, that's a much more invasive, much more costly system where you actually place electrodes within the spine, or you may place an electrode within a peripheral nerve, but often this requires an incision, a small surgery, anesthesia, and doesn't address the issue of ease of use. So well, how does BioWave address this issue? Well, one thing is that the BioWave machine and technology is able to create a high frequency signal in the 4,000 hertz category, and this is able to travel through the skin, as we will see through their percutaneous microneedle technology. These high frequency signals are able to travel into the deeper tissues, and when they get into the deeper tissues, they are able to also cover a wider area. There's multiplication of these high frequency signals, and they create a low frequency electrical field. The electrical field is actually larger and a larger surface area than the actual size of the electrodes themselves. So we're able to deliver the electrical stimulation to a larger area and to a deeper area than traditionally we've been able to do in the past. So what is the mechanism of action? So as we discussed, the electrical field that's created it's what it does is it tries to, and it does effectively block pain signals. And how does it do that? It works by hyperpolarizing C fibers. As we know, C fibers carry pain signals, and by inhibiting the sodium potassium ion exchange across these C fibers, there's a hyperpolarization, and therefore it inhibits action potentials and pain signals that are sent to the spinal cord and brain for perception. It also does this by attenuating the A delta fibers. So A delta fibers are also very important in pain signal transmission. The conduction block that's created by the BioWavePENS is able to create an hypoesthesia. And how do we know this? Is oftentimes patients will tell us when they start experiencing the stimulation, the first few minutes, they may notice some light numbness, some light tingling, and this can last for up to 30 minutes. And we feel this may be related to a blockade or attenuation of the A delta fibers. There are other mechanisms that have been proposed for the BioWavePENS. One is that also affecting afferent stimulation and working on other systems that help control pain. Some of that includes promoting the production of endogenous opioids and endorphins, and other transmitters. There's also proposal of other benefits, such as improved blood flow to local tissue where the stimulation field is present. Some patients will also notice a sense of relaxation of the muscle, or as if they're getting a gentle a massage during the stimulation, and we feel this may be related to the fact that the muscle tends to be held in a tension during the treatment, and this is perceived as a comfortable sensation by the patient. So the other issue, as we discussed, is how do you deliver this high frequency signal deeper into the tissue? Well, one of the things that BioWave came up with was this patented technology is also this as an electrode. As you can see an image of this electrode here, it's magnified for a better view. The electrode is 2.5 inches in diameter. Inside this electrode, you can see these little black marks, and these are a total of 1,014 what we call microneedles. They're each 0.74 millimeters in length. A lot of times patients will say they feel like Velcro to touch, and there's very minimal to no pain on application of these needles. I often describe it to patients as think of it as the size of your hair, because often when you tell the patient that there's needles inside these electrodes, they may be apprehensive, concerned about needles onto their body, but it feels like Velcro, and they're very micro needles with really no discomfort in their application. Again, one of the benefits is, although they're 2.5 inches in diameter, they allow for a 3.5 inch diameter treatment area, which is beneficial to treating pain without having to be exactly on the spot where the pain center is, or the origin of the pain is. So how do we compare this to other technologies that's out there? You may have also know that there's, of course, other pen systems out there. Conventional pens or type of acupuncture type pens is tends to be single needles. They can be 3 inches in length. They are inserted. They have to be inserted very close to the location of the pain or the source of the pain. So you have to be very precise. They tend to provide stimulation to a very localized area. They're also, the response rate is in the 30 to 40% range of patients who benefit. How is BioWave different? This is now 2 electrodes. Each electrode is 2.5 inches in diameter. Instead of having 1 or 2 needles, you have over 1,000 needles. The surface area where the conduction blocks occur are much larger than the electrodes themselves. And you don't have to be precisely within millimeters or centimeter of the pain source or the nerve field, like you will be with conventional pens, or even with more advanced techniques like peripheral nerve stimulation. The placement, as mentioned, is critical, but does not necessarily have to be precise, and there is a much higher response rate. So there are multiple studies out there. I wanted to, without taking up too much time, I wanted to address at least one study that described the use of BioWavePENS. In summary, these studies have come to show that the system is easy to use, that there's compliance in the patient and staff and application of the device. It's the goal of improving pain also goes hand in hand with decreasing the need for medication, specifically opioids. The response rates by patients can be up to 85%, or I should say that 85% of patients who have the application have improvement. That improvement can range in the 40 to 60% range. The immediate relief can last up to 72 hours. Versus something like a TENS unit, which an athlete might use while they're sitting on the bench during a basketball game, maybe only for an hour or two or a few hours. There's a significant increase in range of motion and reduction in stiffness. And I want to come back to stiffness. I think that's one of the things we often hear from our patients is that the pain improved maybe 30, 40%, but the stiffness improved maybe 75%. And decrease in muscle spasticity. And of course, a decrease in medication use, and we've seen this in the studies, up to 50% reduction in use of opioids. This is a study that of BioWavePENS usage from Chicago, from Rush University Medical Center. 70 patients were blinded and randomized into either a live active treatment group and a sham treatment group. The inclusion criteria was osteoarthritis of the knee, either grade 3 or grade 4. The sterile PENS electrodes were placed over the painful locations over the knee, and these patients were studied in comparison to the sham group, as mentioned. The results during the results, the patients were asked about their pain levels, their pain scores, how they felt the stimulation was, and how they felt afterwards. So in this result, the 35% of the treatment group or the live group had noticed that their pain control was complete or well, as mentioned, and only 7% of the sham group had mentioned this. So that was statistically significant. When looked at patient satisfaction at 1 week, the 77% of the active live group noted that their pain was good or very good or excellent, versus 11% of the sham group, again, statistically significant. The study showed decreased pain medication usage within the active group. So definitely significant improvement, significant changes versus having a sham procedure. And this was published in the journal Orthopedics in 2007. So some examples of electrode placement. There are different techniques and different ways, but here are some best practices. So for example, on the left side, we see a lumbar application. This may be a patient with lumbar facet syndrome, lumbar discogenic pain. The electrodes are placed in the lumbar paravertebral area. The image on the right, we see a patient with more radicular pain radiating into the right lower extremity in the distribution of the lower lumbar nerve roots. In this case, one electrode is placed at the source where the of the pain generation in the L4 right side L4 nerve root distribution, and then the second electrode is placed along the sciatic nerve and along the buttocks. Other locations of application for joints, we tend to like to cover the entire joint itself. And you can see here a patient with a right shoulder pathology with a pair of electrodes covering the right shoulder. The image on the right is a patient with sacroiliac arthropathy or sacroiliitis and localized pain as determined on palpation by a positive Fortin's test. And here we see electrodes placed just above the sacroiliac joints bilaterally. Other applications, often, as we know, we have patients with myofascial pain or trigger points identified on physical exam. One common area of trigger points is the trapezius and the suprascapular areas. Here is a patient with left shoulder trigger points with placement of electrodes over the left trapezius. I don't see too many patients with podiatric issues, but there's also effective placement for plantar fasciitis, an example of that on the image on the right. So some best practices when it comes to body positioning, the tissue should be in a taut or stretch position. For the low back, lumbar area, we have the patients in a comfortable sitting position with the trunk 90 degrees to the legs. For the cervical region, we tend to have the patients have a slight head tilt, again, keeping the muscles in a taut position. Um, the um, for the thoracic area, the patients are in neutral position. For the knee, we have the knee bent 90 degrees. And of course, the motion and movement can affect the positioning, the electrical field. So once the patients are comfortable and they have the electrodes placed, then we ask them to relax. And typically they'll read a magazine or they'll read or play with their cell phones, and we leave them in that position. So how do we do the setup, and how do we do the application of the electrodes? It's very, very user-friendly and very simple and time-wise efficient. We have the patients point to their most painful areas. These areas typically correspond to areas of trigger points. The areas are palpated, and the center location is marked with a marking pen. And the skin is then disinfected with some alcohol wipes or alcohol prep. The electrode is prepared. It's peeled back from its protective cup. The electrode is placed. The center of the diameter of the electrode is placed over the marked area. And then we apply some. You have to apply some pressure. This can be done in different ways. You can follow the recommended guidelines of 6 o'clock, 9 o'clock, 12 o'clock, or you basically just have to apply some moderate pressure, not for long, for maybe 10 or 20 seconds over the different areas of the electrode to make sure that it sticks thoroughly on the skin. Then it's connected to the using a cable wire to the stimulation generating device itself. The startup screen then will show you a 0% read, and at that point, the patient is given the device and instructed on its use. This whole setup time usually takes about 3 minutes. So as I mentioned, the patient is really controlling this device. So you don't have to have the medical assistant next to the patient at all times. We do observe the patient every 5 minutes or so, and we make sure that their questions are answered or they have compliance with the system. But the patient is really in charge of increasing the stimulation. We instruct them to increase this by each time you press the plus button, you get a 0.5% increment increase. The maximum intensity is 100%, and you start at 0%. The patients typically will advance this through their tolerance of the system until they perceive a sensation that is strong but still comfortable. As the body adapts to the stimulation, then the patient is able to continuously increase the system at higher levels. This advancement happens throughout the 30-minute session. In the first 5 minutes, as I mentioned, through the effect of A delta and C fibers, there may be some hypoesthesia, so the patients may feel some numbness or some tingling. That passes through, and then they feel like as if they're having a gentle massage. And of course, we encourage the patients to increase the system. Typically, in the first half of the stimulation time, we try to achieve about a 25% intensity. As time goes on, we try to increase it from there close to 50%. There are different endpoints, and typically from one session to another, we will try to push this even higher up to tolerable levels. So according to body location, there are some experience on stimulation levels in the lower extremities and the knees and the ankles. Intensities typically range from the 30 to 50%. In the lumbar and thoracic areas, 25 to 40%, in the upper extremities and neck, somewhere between 15 to 30%. And the minimum intensity level we try to achieve is 15%. I can tell you that one thing I've noticed is some patients, when you, of course, you describe the system and they have this idea of needles on their first session, I noticed some patients are very shy, and they tend to be in the 5%, 10%. So we don't push them too hard on the first session. I think the first session is to get used to the device, to get comfortable with it. And then usually I've noticed on the second and third sessions, they tend to be more bold and more aggressive, and we're close by to answer those questions for them and to support them during this process. So what happens at the end of treatment? Well, at the end of treatment, the system countdown reaches 0 minutes per second, and the frequency or the percentage drops to 0%. The maximum intensity is displayed on the LCD screen. This is important because you want to record this and document this in your medical records. We peel the electrodes off the skin. We place this into a disposal, sharps disposal, like you would do any other needle. Oftentimes you'll see an area of redness, and you might see some dimpling at the treatment site. This will be more evident in fair-skinned patients. Occasionally, you'll see some very tiny droplets of blood present. We clean this with alcohol wipes. We don't place Band-Aids or any dressings on top of this. This erythema over the skin typically will resolve within a few hours. The patients can shower later in the day. If they want to use a jacuzzi or something like that, we tell them, the following day or 48 within 24 to 48 hours, they can have access to that. So a few case examples of patients that we've seen recently in our practice. I want to describe this first case series as a patient, a 25-year-old male who was rear-ended in a motor vehicle accident. He underwent conservative management for about 10 weeks. This included physical therapy, chiropractic therapy, taking anti-inflammatories like naproxen. We also applied topical diclofenac or anti-inflammatories to the back. The patient was eventually diagnosed as having a whiplash type injury to the back, diagnosed as lumbar facet inflammation or lumbar facet syndrome. He had a lot of lumbar axial pain, worse with sitting, worse with standing, worse with lumbar range of motion. So at this point, we offer the patient lumbar facet injections with platelet-rich plasma or PRP. We also offered him BioWavePENS. The patient elected to undergo the BioWavePENS sessions. We recommended 4 sessions for him. He had a very busy schedule, and the 4 sessions worked very well for his schedule. The electrodes are placed over the around the L3, L4 areas, just just lateral to the spinous process in the lumbar perivertebral areas. The average intensity achieved by this patient was in the 40 to 50% range. And on follow-up, 2 weeks afterwards, the patient had noted 70% improvement in their pain, and we haven't seen the patient back for any other pain condition since. Second case is a 25-year-old female who suffered a slip and fall down a flight of stairs. She fell onto her right shoulder and had significant right shoulder pain. This was treated initially with Celebrex, physical therapy, muscle relaxants, and after 6 weeks, the patient had only mild improvement. An MRI showed us right supraspinatus partial tear with some bursitis in the right shoulder. So normally at this point, we offer, typically in the past, we would offer shoulder injections in the form of platelet-rich plasma versus steroids. As I mentioned, because of a growing group of patients who also want to exhaust further conservative management, we also offered BioWavePENS. The patient ended up having electrodes placed over the right shoulder, anteriorly, posteriorly. The patient had 6 sessions over the course of 3 weeks. Maximum intensity achieved was 35%, and the patient improved 50% on follow-up. However, interestingly, because of some ongoing pain, the patient elected to undergo our original recommendation of platelet-rich plasma or PRP injection to the right shoulder. Again, I felt very comfortable with this treatment, and again, I think the fact that we were able to build rapport with her through the PENS treatments, we were able to offer some other treatment, and she felt comfortable that although she had improvement, she knew that she had exhausted all conservative options, and now she was comfortable undergoing the PRP treatment at the end. And after PRP, she has now about 90% improvement in her shoulder. So just to summarize this presentation, I'd like to say that in our practice, in our busy community pain management practice here in Los Angeles at CSPP, or Comprehensive Spine and Pain, PENS for us has shown to be a simple, safe technology that has proven to be efficacious for our patients. This is a patented, unique technology, and is easy to apply and easy to use. There is immediate effects that can be seen up to 72 hours, and there's cumulative effects after multiple usages. Doesn't require extensive programming, as we said. In fact, no programming at all, and there is good patient satisfaction. So we feel this is an excellent tool to use in your armamentarium of multiple different options that we have in treating patients. It can be considered prior to going on to injections or surgery, and we've been happy with this, and happy to field questions, and I'm happy to be a resource for you if you would like to discuss this further. So thank you, Brad, for the time to make this presentation, and I'll put the floor back to you.
Thank you, Ray. That was a great presentation. We have received a number of questions in the Q&A, and excuse me. So let me tee them up for you. The first question is, are there any logistical challenges in scheduling and managing patients during the BioWavePEN sessions?
Thank you. So, these sessions take about 30 minutes themselves to run, but you have to prepare the patient, and then you have to discharge the patient. So, you're anticipating about 40 minutes, 35 to 40 minutes in the room time. Maybe 35 is reasonable, but that does take up a space in your office. So what we do is in our office, we use the recovery room. We have a small recovery room where we have 2 bays. So we use those as locations, or if we use it in our existing exam rooms, we just have to anticipate that those exam rooms are going to be busy with PENS patients. So it's just important to organize your day in a way that you have, it doesn't slow up the routine of your clinic, and you're able to see patients quickly. So we typically tend to plan for anywhere from maybe 6 to 8 PENS sessions per day in one of our locations. We have multiple locations, so we will scatter them out throughout the different locations. But just something to be aware of as your clinic flow, so you don't have a bottleneck as far as patient flow.
Thank you. Next question, and this is always a big question, which payers will approve and reimburse for BioWavePENS?
Okay, thank you. Yeah, that is one that's of importance to every doctor, because they want to make sure that there's something that they cover their costs and of course make some money from the procedure. We use it essentially mostly for personal injury cases. We have done it in the past for some cash cases, and we have done it also for insurance in the past. Insurances in the past, like Blue Shield, Aetna, you have to obtain authorization. You usually obtain authorization for all the sessions, whether it's 4 or 6. And we have had some fair reimbursement for those cases, but currently in our practice, we use it mostly for our personal injury cases. And we've had, we've had some, we get reimbursements which are definitely fair reimbursements, and haven't had too many issues with regard to that. I'm sure, Brad, you might have some more input nationally. There might be some different trends, for coverage and reimbursement throughout the country.
Yeah, I would generally say the focus of most of our pain practices are ones that are using BioWave pens to treat patients in personal injury cases and in workers' compensation cases. Those that's really where the focus is and where reimbursement is very widely available. Next question. Are there any trends in responders versus non-responders to BioWave pens?
So some of the trends that we've noticed is that people who tend to do better with these procedures, who we term as responders to the treatment, which are a large portion of the patients, are the ones that are the ones who tend to increase the percentage of stimulation from treatment to treatment, and both within treatments and in between treatments. So, they don't mind. We educate them on increasing the percentage from maybe from 5, 10, 15% up to 25%, 30% on their first session, and then as with each session to try to increase it. I've noticed with some patients, they're just, the idea of these, a patch with needles inside, they might be scared of the electricity, or they have some concerns about that. And if they're a little bit shy about that, I've noticed the ones who have lower percentages tend not to respond as well as the ones who achieve the higher percentages that we talked about in the previous slide, which is usually somewhere between 25 to 40%, 30 to 40%. I can't say that if someone gets to 80, 90%, I've had some patients turn it up, crank it up really high. I haven't necessarily seen those, meaning that they're going to have significantly higher response. The other point I will make is that patients who have vague pain, who might have, let's say they have upper back pain, but it radiates to the upper back, to the low back, they tend to have pain everywhere in their body. Those are, I would say, are more of the non-responders. I feel like the responders have more focused area of pain. It might be the shoulder, the anterior, posterior shoulder. It might be the cervical and upper back. But if it's a more localized area, I feel like those patients do better, and the patients who increase their percentage of stimulation within each session.
I think that's very typical. We find that in other practices as well. The point you made during the presentation, where the first time a patient has a PENS treatment, they don't know what to expect, so they tend to go more slowly. They don't go up quite as high, but once they're used to what the sensation's like and what to expect, they do tend to increase at a faster rate and go to higher intensities with future treatments, and that helps. Generally speaking, the higher the intensity, the greater the efficacy, the longer the residual benefit. But the treatment, while it should be strong, it should always be comfortable. So the patient, there's a happy medium as to how high the patient should go. Next question. Any adverse events or complications that you've seen to this treatment modality?
We haven't seen any severe complications or any significant complications, but we have seen some reactions, I'll call them. And this is, again, going back to what we talked about, how we schedule these patients. We always make sure that there's a provider, either a physician or a nurse practitioner in the building or in the clinic. Of course, the medical assistants are available, and they help sort of direct the patients and help with the application and the education when they're there. But we have physicians and nurse practitioners available. Why? Because there are occasional times when there can be very mild reactions or adverse events. So the ones that we've seen in our practice have included, we've had a few patients who had vasovagal reactions, sort of one felt faint in the chair. and looked a little pale, was faint. We gave them some apple juice. We checked their vitals, and we sort of we stopped the stimulation. We rescheduled for another day, and that patient improved. We had another patient who stood up and passed out briefly. So I never close the door on these patients. I don't put them in the room and close the door. I always leave the room ajar. We check on them every 5 to 10 minutes. Usually it's about 5 minutes. We walk by the room, we can see them. So I wouldn't just put them in the corner of the office and close the door. I would keep my eye on them. Again, these are very rare events, but they can occur, and we need to be aware of them. We've had a few patients who've had rashes or skin redness and a little bit of localized skin swelling. We usually treat that with Benadryl, sometimes topical steroids. And again, going back to the fact that these are microneedles that are being inserted into the outer layers of the skin. And so for that reason, we do have a setup to deal with these, to observe these things. But there's nothing that we have not had any long-term complications from these treatments.
With respect to like rash on the skin, I would just point out the microneedles are made from 316L surgical grade stainless steel. It's the same material that the case of a spinal cord stimulator is made of, which is implanted in the body. But that material does contain very minute amounts of nickel, and patients that may have metal allergies typically may have a sensitivity to nickel. So that's if that may be a case where you might see a slight rash on the skin. So I just mentioned that. Next question is, are any best practices for documenting and record keeping of BioWavePENS sessions?
Yes. So we've, over the years of doing this, we've come up with what we feel has worked well for our practice. So we basically, what we do is we have a paper record and we have the electronic medical record. So, and we do that to make sure that if there's ever any discrepancy, or we don't, or for whatever reason the EMR record is not available, we have the paper record to go back to. So when the patients come in and they get their treatments, we document on a piece of paper with our company logo and information on it. We document the patient's information, their name, their medical record number. We document the highest percentage of stimulation that they achieve. We document their pain scores before and after, and any stiffness, muscle pain, muscle stiffness before and after treatment. And we keep those scores on a piece of paper that we scan in and as a document in our record. But we also convert that into a procedure note within the EMR. So that becomes the electronic medical record, but we always have a backup for it. I definitely recommend doing that, because there's always times where you might not have the EMR might have a problem, but you can always refer back to your paper documentation.
Great, thank you. Next question here is this treatment good for joint pain with arthritis, with the effect of swelling on the knee and a meniscus tear? I don't know if you have experience treating those types of patients, but I can also comment on that after you.
Sure. Yeah, I would say majority of I would say 80% of what we do is spine related, muscle, spine related, back related. I would say about 10 to 20% is joint related. So we have a little bit less experience there, but we do use them for joints. We've had just as good response with joints as with other areas of the spine. I can't say that I've remember or evaluated swelling afterwards to tell you whether it helps with swelling, but I do notice that patients with joint will notice with incremental treatments improvement in joint range of motion, less stiffness, less pain. And I would say only a minority of those patients go on to injections. Maybe like 10 or 20% of the patients who get joint pens will go on to further treatment. I don't know, Brad, if you have a different experience.
No, that's so we have a very large patient population in the Veterans Administration. We treat a lot of veterans across over 200 different hospitals and clinics around the country. A lot of that, it's almost entirely chronic pain. A lot of it's chronic low back pain, chronic neck pain, but there's also a lot of chronic knee pain. And we have a lot of success treating patients with chronic knee pain. And a lot of that is from osteoarthritis. And it might be, anything from grade 2 to grade 4 osteoarthritis. And the study that you actually talked about was a study on grade 3 and grade 4 osteoarthritis of the knee. So that is a good application for BioWave. With respect to meniscus tears, we also treat most professional sports teams, and the majority of the major college sports programs all use BioWave, not only to help keep athletes in the game, but to facilitate rehabilitation following injury and following surgery. And certainly meniscus tears are a big portion of what happens in a lot of different sports. And so I know we have good results treating pain that results from meniscus tears in the knee because of all the work we do in sports. So I just wanted to add that. Next question. What are the best ways to integrate BioWavePENS without alienating a chiropractor or physical therapy colleague that you might have in the practice?
Yeah, that's a good question. That was, originally that was a concern that we also had when we incorporated this modality. I think you need to do some education with the physical therapist and the chiropractor, so they understand that this is not a competitive product, that this is something that we it's not the first line of treatment. So usually patients will have physical therapy, they'll go see their chiropractors. There's other types of electrical treatments. For example, the chiropractors often use TENS units. There are other types of acupuncture type procedures that they'll incorporate into their offices. So if these are limited and if these fail and the patient continues to have symptoms, usually 8 weeks, 10 weeks, 12 weeks, 16 weeks after is then when we incorporate BioWave. So it's not seen as something that's competitive. It's not something that's going to cannibalize their ability to treat their patients with their modalities, which are usually entry level modalities and at lower costs. So we always want to start with those first. Right. And I think the discussions I've had, and I've actually invited some of the therapists and the chiropractors to the office to see the application and see the procedure. I've shared with them some of the slides and some of the pictures of the device, and that really sets them at ease, and they understand that this is something that is on a different level. If their patients continue, if they can no longer help their patients with their modalities, this is the next level that they can refer up to.
Makes complete sense. Two more questions I have here. This first one is, can BioWavePENS be performed by a nurse practitioner without a doctor present?
Yeah, so nurse practitioners, I mean, every state is different, but nurse practitioners and physician assistants are increasingly independent. In fact, I think nurse practitioners can practice medicine in many locations, even without a physician. But as far as there's two parts of this question. The first part is the logistics part and the legality part, and then the second part is the actual safety part. Can they handle? So as far as the safety and the practicality goes, the answer is absolutely yes. The nurse practitioner can handle any potential complications as far as the reactions, skin reactions, vasovagal, and they can also help educate the patients and help with the application and recommendations on best practices. As far as the legality part from it, we're with our nurse practitioners, you always want to be either within the same location or you want to be immediately available for them. Again, depends on the type of procedures. If they're doing something that's very invasive, you need to likely be on site and nearby. If it's something that's less invasive, then you can be available by phone. Again, a lot of this depends on the state. I understand some states nurse practitioners can can practice medicine without a physician available, or that's something that's going to happen sooner than later. But yes, the answer is yes. We've never had any issues with that, but we always will have a nurse practitioner or a physician available nearby when these treatments are being done.
Makes sense. Yeah, I think every state's going to have slightly different regulations or rules relative to this. Last question, can you reuse the perc electrodes?
Okay, well, the answer is no. That's a good question, because it brings up the point of how do you manage these electrodes? How do you handle these electrodes? So we treat these electrodes just like a needle, and in fact that's what they are. So what does that mean? That means when we take the seal apart, if it falls on the floor, we throw it away. And that's happened before, by the way. I've had a time when the MA, hey, Dr. Tatevossian, it fell on the floor. Should I just wipe it off with alcohol and apply it? And the answer is no. The answer is no. The answer is you throw it away. And where do you throw it away? You throw it away in the sharps container. So you can just peel it onto itself, so the needles are not exposed, and we throw it away in the sharps container. And we treat it like anything else that's sterile. You want it to be sterile when it applies to the human body. If it's not sterile, you throw it away. And it's one-time application only.
I would add, just so people really understand, when you remove the electrode from the skin, the needles all bend a little bit. So even if you were thinking, well, I could just reapply it to the same patient, if you would try to insert the needle array back down through the skin, some of those needles might bend over and be flat on the surface of the skin. So you would create hot spots and the patient would get a burn. So not only is it no longer sterile, you risk burning the patient. So you can never reuse a percutaneous electrode. That's all I have here in questions from the group. So I want to thank you for your time. I thought this was a great presentation. The questions were great, and thank you very much for your answers. And this webinar will be available to view on our website and on our Google channel, hopefully within the next few days. So thank you very much for attending, and please join us for our webinar next month. It'll be mid-month sometime in October. So thank you again.